Hello, I think we can start. Good evening, everyone. I welcome you all to this 4-day course on pharmacogenomics and personalized medicine. Today, we have our speaker here, Dr. Neha Suratiya. She is an ex-assistant professor from Parallel University. She has keen interest in research and academics. She is an author of book under the title Drug-Related Problems and Their Overcomes. She has authored 12 paper publications in various national and international journals. She has presented and participated in various conferences, workshops, seminars, panel discussions, etc. She was certified to serve humanity during the COVID crisis at Dheeraj Hospital. She developed knowledge in clinical and pharmacy practice area, making her an expert in this field. Her vision is to create a service provider by utilizing clinical skills and moving away from the current supply chain based model. I welcome you, ma'am.
Thank you. Thank you for this kind introduction.
Thank you, ma'am. We are so glad you could take out the time and do this session for us, ma'am. We can get started while the others can join us.
Okay. I think it's 86 participants in the room. Can we start?
Yes, ma'am. We can start, but the others can join us meanwhile.
Okay, no worries. So, good evening, everyone. It is a very good opportunity to learn pharmacogenomics and personalized medicine. Let's not waste much time onto it, and I will be sharing the screen with all of you. Throughout the lecture, if you have any query, you can note it down, and at the end of the lecture, you can raise your hand, or you can drop the message in the chat box, or you can unmute yourself and ask. I will request you to please, make a notebook if possible, so that you can, have the points in your notebook to read afterwards. Because at the end of this 4 days course, we will be having a MCQ exam. So this is the gentle request from my side. Whatever is convenient to you, you can make notes into it. So, okay, I will be sharing screen with all of you. Okay, is the screen visible?
Yes, ma'am.
Okay. So, very interesting part of genomics. We will going to start one minute. Okay, so the course name itself, it is a pharmacogenomics and personalized medicine. In very first lecture, we are going to discuss about basics of pharmacogenomics, because I am not aware of what background you might be having, but it is very important to know the basics of pharmacogenomics before proceeding towards the next topic, which is personalized medicine. So it is my absolute pleasure to welcome you all to this 4 days journey of course on genomics. Genomics itself, it is a vast and ever evolving field, and that holds, the key to understanding the living life at its most fundamental level. Now, though it is a deep and complex subject to understand, because pharmacogenetics, of course, everyone is aware about it, how complex it is to understand. Over the next 4 days, we aim to make it engaging, insightful, and applicable itself to your field of interest. And this course will, provide you with a solid foundation and the concept clarity of genomics, covering its importance, its principles, its application, and its future potentials, we can say. So whether you are a student, whether you are a researcher, or any professionals you are having in the pharma field, I encourage you to make the most of this opportunity. Okay, ask as many as questions you can, engage yourself in the discussion, and explore the exciting possibilities that genomics has to offer. Thank you for being here, and I look forward for the enriching learning experience together. Let's get started with the very first lecture of our course. And the very first lecture is, as I earlier said, it is on the basics of pharmacogenomics, and we will be having a gene drug interaction. So let's understand what will be the learning objective of today's lecture. We'll see the importance of pharmacogenomics by a one very good examples that include its definition and the role in patient care. We'll understood about the mechanism of gene interaction with examples, and we'll understand about genetic inheritance with its types. So that is, I think, very clear objectives for the first lecture of 4 days. I think this is very basic, but I need to start with this basic of pharmacogenomics because genomics is a quite new term and it is recent branch to study. See, the name itself suggesting a pharmacogenomics, it is having a two name inside it, the pharmacology and the genomics, right? Pharmacology, everyone is aware about it, the PKPD mechanisms, okay? Pharmacokinetic dynamics, what body does to the drug, what drug does to the body, and everything. And genomics itself, the name suggests that the mechanism of gene, what is the role of gene in the body, right? And when you combine the term pharmacogenomics, basically that defines as the role of gene in the drug response, how it is going to be effective, right? So everything is connected, and this pharmacogenomics is a very vast subject to understand, but we'll try our best to cover it all up with the lecture. So let's start with the very first thing, that is the definition of it. As I earlier said, a pharmacogenomics having two different terminologies, that is the pharmacology and genomics. So the definition is very simple, is the study of how your new genes affect a person's response to the drug. And pharmacology, the science of the drug, including PKPD, and genomics is the study of genes and their functions, both terminologies combinedly used for what? To develop effective, safe medication that can be prescribed based on person's own genetic makeup. That's where the precision medicine or personalized medicine stands for, right? So that's where the concept of precision medicine come. So you are looking for the pharmacological aspect of the drug. You are looking for person's own needs according to their genomics, according to their genetic makeup, according to their lifestyle, their diet, and then you are prescribing something which is convenient and effective for the particular patient. That's where the precision medicine or personalized medicine stands, right? So let's not talk about personalized medicine because we have another lecture separate on to discuss about it. Today's lecture we are focusing on, the concept of pharmacogenomics. Okay, now to understand the importance of pharmacogenomics, I think I would like to share one story with all of you so that you can have a better idea of what is the importance of pharmacogenomics in our daily life, right? So I would like to request you all to imagine a scenario in your mind and put yourself in the main character that it is going to be, happening with you. So focus on the story. Then at the end of the story, you will have the clear idea why we are studying pharmacogenomics and what its importance. Okay. So let's get started. Imagine you are a new mother having just given birth to a healthy baby boy. What happened next is, unfortunately, the delivery has left you with the debilitating postpartum pain, which is very normal after pregnancy or after giving birth, right? So, as normal person, you are also visiting your doctor, and doctor prescribe you a painkiller, which really helps, but also makes you feel drowsy, tired, and sometimes constipated. Now you can imagine what kind of painkillers are widely available in the market, and doctor are widely prescribing that to the new mother for the pain management. So we can say at the same time you notice that your son isn't breastfeeding very well, so you are suffering from the postpartum pain, and at the same time you notice that the son isn't breastfeeding very well. You again visit visited the doctor's clinic, and this time doctor assures or reassures you that everything will be fine and recommend you to store your excess breast milk for your convenience, and you go home relieved. But what happens next is one day the child doesn't wake up. So you can imagine a effect of painkiller, right? His skin is gray and he is not breathing at all. Frantically you call hospital, but it's too late. Authorities arrived and autopsy is done, and they checked the blood reports of the baby, and what they found is high level of morphine in the baby's blood. Now you can imagine a scenario, in this case, what, whose fault is this? Basically, the doctor's fault, the patient, or the pharmacist who delivered the painkiller. Whose fault behind this baby's death? Extremely high level of morphine was found in baby's blood. Now that is very, very serious concern about a painkiller that led to the death of the baby. This is the true case published back in 2006 into the Lancet, and that is the codeine effect. So there is a true case study published in Lancet back in 2006, where that's where the pharmacogenomics started, and everyone was very concerning about the terminology of genomics, that what is this and how it is going to be effective, because for it, this painkiller is quite common, and every mother after the postpartum delivery, if they are suffering from pain, they are prescribed with the same painkiller and not at all having any issue. But what's different in this case? Why this case is published? So this is the codeine effect, and this is structure of the codeine that is having methyl group and a number of phenol rings into it. And you can check after this lecture. You can I mentioned the link in the chat box. You can read this article because this is very important article actually. वहां से ही शुरू हुआ था कि what is the importance of pharmacogenomics, right? Let's understand the brand that was prescribed at that time, that was Tylenol, and that is with the codeine number 3. This medicine, particularly now, it is banned in US, but it is quite popular in India under the another brand name. So we can say codeine is found in the Tylenol number 3, which is a very potent painkiller prescribed to many new mothers to relieve a postpartum pain. And yet, the vast majority of these breastfeeding mothers have healthy babies. But in our case, the baby isn't at that time not able to breastfeeding very well. So mother has to store the breast milk for later for use for their convenience. So what happened in our case? Let's understand. In our case, there is a major role of gene. Okay, because everyone in I think aware about it. Codeine itself, it is a weak painkiller, right? But that can be converted into the morphine to act as a painkiller, you know so to show its efficacy, codeine has to transfer it, or we can say convert it into the morphine. And for this mechanism of conversion, we required an enzyme to metabolizes a codeine, and the enzyme which is CYP26, right? CYP450 enzyme family. Very important to understand, all of majority of the drugs are metabolized by our CYP450 family enzymes. So we have to be very active to understand what is the relation between gene and a drug. Let's understand, a person is taking a drug. What happens next is drug can be metabolized by the phase 1, by phase 1 and 2, by phase 3. If it is metabolized by the phase 1, CYP enzymes are the playing major role. They can be transferred into the oxidized form of the drug. They can be either by the phase 3, we can say detoxification pathway through. They can be converted, the drug, it can be converted into the conjugation form, or the drug can be transformed into the reactive metabolites, which might lead to toxicity. So these are the possibility of the drugs after consumption. And what happened next is drug can be in the two of the forms: inactive metabolites, that can be the result of loss of the drug activity, or drug might have to convert into the active metabolites. That might be the three different possibility again, that can might lead to toxicity, different biological activity which are desired one, or we can say altered drug activity which is undesired drug activity, right? So these are again the possibility after the ingestion of the drug, right? But in this thing, the very important thing we are learning, that is the cytochrome P450 enzyme, and that's where our genetics stands. These are the enzymes which are responsible for metabolism of the drug. So 80 to 90% of the drugs are getting metabolized by the CYP450 enzymes. They required a NADPH as a ATP to metabolize the drug, later. Now, the role of CYP450 in drug metabolism, very short and brief diagram is here because that is completely a different topic to understand in detail about the role of CYP450 family in drug metabolism, how it is metabolizing, right? So we can say the very first is the normal binding, where the enzyme is there and substrate is coming and the active site is there. So they can be having a lock and key mechanism and the normal binding takes place, and then the desired activity will be there. Second one we are having, that is a competitive inhibition, where the another competitor will be there which are having an active site location, and there will be a competition between substrate and the competitor. And the another one that is having a non-competitive, two different things are there and two different sites are there. So that is again divided into the very long theory, the role of CYP450 in drug metabolism. We'll try to cover it up in the next lectures, but for this pharmacogenomic concept, I think this is very basic to understand the role, okay, in CYP450, how it is going to be metabolized. So let's understand what happens in our cases. There are over 50 different isoenzymes of CYP450 and 7 to 8 of which are involved in metabolizing over 80% of the medications. You can see the chart here. So यहाँ पे आप देख सकते हो CYP3A4 and CYP3A5 are the 30% responsible of metabolism of the drug, right? CYP2D6, CYP2D6 again 20% is responsible. Codeine-like drugs are metabolized by the CYP2D6. I have put the examples also in this presentation, so you can later you can read in from the PPT that what are the major drugs that can be metabolized by which kind of enzymes. But this is a very basic understanding of CYP family, which are having a percentage of metabolizing drugs. In our case, what happens? In our case, there is a case of codeine. You can say a pharmacogenomics of morphine poisoning in a breastfed neonate of a codeine prescribed mother. It was a case of codeine. So we will focus on CYP2D6, okay, CYP2D6. To understand the importance of pharmacogenomics, we are just having an example of it, okay. Let's understand the CYP2D6 gene sequence again varies between the people. It is different. This genetic variants, or we can say alleles, that result in the slight structural changes in CYP2D6. What happens next? Everyone is aware about it that each person is having two different alleles, one from each of the parent, right? So to synthesize a CYP2D6 enzyme, a person is having two different alleles from their parents. So they can be categorized based on what kind of functional alleles they are having, which alter how effective the enzyme is at metabolizing drug. So broadly, they can be categorized as, we can say, a person can be of rapid or a normal function activity, a person can be of decreased function, and a person can be non-function at all. Different function capacity of a person depending on which kind of alleles of enzyme they are having from their parent. So normal function, if they are having, metabolizes quickly and as expectedly, we can say. If the person is having decreased function, they will metabolize drug very slowly. And if the person is having non-function, they will not at all metabolize a drug moiety, which is having, which are having necessity of particular enzyme to digest the drug. Let's understand. Since we inherited a copy of each gene from each parent, each person have a two CYP2D6 alleles, as we earlier discussed. Based on the combination of person's CYP2D6 alleles, they can be further classified as extensive or a fast metabolizers, intermediate or a normal metabolizers, and the poor or a slow metabolizers. Okay. For extensive or fast metabolizer, which are normal, a person needs to at least have a one functional alleles. So अगर parent के पास से एक functional alleles if they inherited, then they will be categorized as a extensive or a fast metabolizer. Another possibility is too slow allele to be a rapid or a extensive metabolizer. So too slow can be also sum up with the fast one, right? For intermediate or a normal metabolizer, one slow allele or one non-functional allele to be intermediate metabolizer. So that is very easily understandable. That is very easy concept to have the understanding. And poor meaning two non-functional allele to be a poor or a slow metabolizer. I have included a whole different slide on different possibilities of combination of alleles to have a fast metabolizer or an intermediate metabolizer or a poor metabolizer. See, This is the slide of percentage of CYP2D6 metabolizer. See, I am not talking about CYP450 enzyme family. I am focusing on only a one family, that is family member, that is the CYP2D6, CYP2D6, which is responsible for codeine-like drugs metabolism. To understand our case, okay? So, see, you can see a majority of the population, 77 to 92% of population are having a rapid or a normal metabolizer category. Possibility of the alleles, you can see the green color suggests the normal function allele, D suggests the decreased one, which is in yellow, and red, that is a non-functional allele. So if the person is having two normal allele, they can be categorized as rapid. One normal and one decreased, again in previous slide we understood one normal allele is enough to be categorized as a rapid metabolizer. One normal, one non-functional, still you are a rapid metabolizer. Two decreased, again you are a rapid metabolizer, right? Intermediate metabolizer, 2 to 11% population fall under the category of intermediate metabolizer. One non-functional and one decreased, that will be the possibility to be a intermediate metabolizer. And poor one, meaning there is a two completely non-functional alleles, okay, from each of the parent. So you can see this poor metabolizer having very less ratio, 5 to 10%. Again, you can see a dark blue or I think violet color, that is the ultra rapid metabolizer, a very rare category where 1 to 2% of population falls. They are having more than two normal alleles in a combination. So they are having a three normal alleles. Now they will be having ultra rapid metabolizer. I would like to ask you all, what happens when the same diagnosis have this population having a same diagnosis, and you are giving them a same dose of medicine to cure, but the population are having different metabolizer category. What will happen next? Our expected half life of the drug, are we going to achieve or not? No, right? So basically this is not possible at all. Those who are fall under the rapid metabolizer, they will met our expectation. But those who are having poor metabolizer category, they are not going to be match that half life concentration. You will further categorized, or you will be having another dose of the drug after 6 hours later or 12 hours later, but the concentration will still be in the blood of the patient in the case of their poor metabolizer. Now, this is the importance of pharmacogenomics. If in this case, if we are having an idea of patient having which kind of metabolizer category, we can modify the dose. We can modify the dosage intervals, and we can, save them with the toxic effect of the drug which are undesired. So that's where the pharmacogenomics stands, right? So this is a very good understanding of the case, that at what place a pharmacogenomics stands. We can say, see, if we are having an idea of this metabolizer category, this tragedy could have been avoided. जो हमने आगे देखा, okay, the case. If the doctors knew that the mother in that case was an ultra rapid metabolizer, they can change the dose or the dosage interval, or maybe the substitute of the drug. So this is the importance of pharmacogenomics. The majority people are the rapid metabolizer, as we can see in the slide. In very rare case, a person can be classified as ultra rapid metabolizer. Only 2 to 3% of persons are having that category, right? See, these are the category of metabolizers. We are having fast metabolizer, intermediate one, rapid one, ultra rapid one, and in our case, the focus was on ultra rapid. This ultra rapid have three normal alleles of CYP2D6 rather than two. क्यों हुआ ये? Because due to the gene duplication or mutation, many n number of reasons are there. And so they metabolizes certain drugs extremely rapidly and efficiently, because they have more enzyme, right? They have more enzyme in the body, CYP2D6. Basically, this enzyme is derived, synthesized in the liver, and they are having more enzyme, so they will be having a more frequent metabolism of the drug. Changes in the metabolism can alter the effectiveness and toxicity of the drug itself. So, codeine. Let's understand the case which were published in the Lancet. Codeine is converted into morphine, which is the activate form of it, with the help of CYP26 enzymes, which nothing else the mechanism is. It removes the CH3 group. Okay, that's the only reason I put the chemical structure of it. Codeine itself is a weak painkiller, but it's still used because CYP26 metabolized around 10% of the codeine into morphine, because morphine is the active form of it, right? Morphine is a potent opioid analgesic. Everyone is aware about it. Codeine is a prodrug that needs to be activated into a morphine by our enzyme to be effective as a painkiller. So this is the CYP26 normal metabolizer enzyme which synthesized from the liver, and that converts your codeine inactive form into the morphine, which is the active form. Okay. Let's understand poor, intermediate, normal, rapid and ultra rapid category. Now consider if all the type of metabolizers were given the same codeine dose, which is in the practice now, and ultra rapid metabolizers would convert way too much codeine into morphine, right? Theoretically, क्या होना चाहिए? Theoretically they should be receiving lower dose to prevent what? Overdose. In our case, अगर डॉक्टर को पता होता, if the doctor was aware about कि मदर जो है वो अल्ट्रा रैपिड मेटाबोलाइजर है, तो the dose can be adjusted. Okay, so if we can say the lower dose to prevent overdose, we can have the a number of changes into it. So let's understand our case. It turned out that mother in the case was an ultra rapid metabolizer, and the excess morphine which was entered into her breast milk and into the sun, which likely to cause overdose. High level of morphine were found in the breast milk, supporting the explanation. Autopsy were done and हमने देखा आगे की autopsy का report आया था कि excess morphine was found in the breast milk. Okay, so and that is the only reason behind the death of the neonate. See, after this case, the Food and Drug Administration in 2007, they come up with the headline that the risk of infant exposure to codeine and morphine through the breast milk should be weighed against the benefit of breastfeeding for, for both the mother and the baby. Caution should be exercised when codeine is administered to a nursing woman. If a codeine containing product is selected, the lowest possible dose should be prescribed for the shortest period of time to achieve the desired clinical effect. And in 2017, they again added a new line, that is the warning into the onto the label, that the breastfeeding is not recommended when taking codeine or tramadol medicine due to risk of serious adverse reaction in breastfed infants. This can include a sleepiness, excess sleepiness, difficulty in breastfeeding, or a serious breathing problems that could result in death too. So this is the importance of it, and there is still a lot more things to learn about pharmacogenomics before it can really help into the clinic. But new links between genes and drugs are being discovered every single day. Unfortunately, we just don't know who are the right people unless we do a genetic testing of particular patient. So we can say, is a codeine a bad drug? No. The takeaway from this story isn't to say that the codeine is a bad drug and it should be banned. It is a quite an effective painkiller if it is used in the right people. But unfortunately, again, we just don't know who are the right people unless and until we do a genetic testing, right? But genetic testing is again a very, we will discuss the challenges in genetic testing as well in the course. Genetic testing is quite expensive and has number of implications on privacy and ethical issues. In our second lecture, we have a topic of personalized medicine, and we have a topic of social, ethical, and legal issues in this field, right? If you are going to practice a personalized medicine, what will be the issues you are facing? This story isn't just about codeine and CYP26. I just had a one example into it, right? So these are about the 90% of all the medicines a person is having. Most of all the drugs are metabolized, not a combination of CYP450 enzymes and another combination of phase 2 enzymes. Those are, we can say, TPMT, phase 2 enzymes are TPMP, that is the thiopurines methyl transferase. We are having UGT, that is the glycosylate transferase category. So those are the another phase 2 enzymes which are responsible for it. And many of these enzymes have a genetic variations into it that can change their function, altering the effectiveness and resulting into the drug toxicity. So that needs to be addressed actually. Genetic testing and variations are the major cause of ADR. Genetic variations are the major cause of adverse drug reaction, and which is a huge burden itself on the healthcare system. What is the solution of it? The one and only solution we are having is DNA profiling, right? What is DNA profiling? So you have a mixed population. The poor metabolizer will have a decreased function or a bad side effect. You have a good response population, and you are having no response at all, but they are in a group. Profiling can add, and by the profiling you can segregate people. So DNA profiling is nothing but a series of tests, okay, and the techniques which are employed to evaluate the identify, we can say, basically the genetic information which contains within the individuals. And in forensics, DNA profiling is quite popular in the forensic field, but we can practice in the precision medicine too. See, in another words, we can say a precision medicine. Imagine if we can use a pharmacogenomics in this thing. What happens next is to prescribe each individual patient the most effective and least harmful medication based on their genetic makeup. In another word, we can say a precision medicine concept, right? See, this is the personalized medicine. Big person itself is having a own genetic makeup. So according to their genetic makeup, a medicine is chosen by the doctor or a pharmacist. Some person is having a requirement of a whole pill. Some might be having a low dose requirement. Some might be having a double dose requirement. Some at all not required a medicine to heal. So those are the different category of the people according to their genetic makeup. Not only it could prevent the baby during the toxic breast milk, that is a very popular example, so I had put it, but see, there are many other things are also there. The very first we discussed codeine activated by the CYP2D6. Okay, rapid ultra rapid metabolizer. Mother converts too much codeine to morphine, which enters into the breast milk and which will be resulting into death. Another category we are having, that is the very popular drug azathioprine, which is inactivated by our phase 2 enzyme, which is TPMT, right? The ADR क्या है इसका? Poor metabolizer category. Now imagine if the person is having poor metabolizer category, they cannot inactivate azathioprine. What happens next is buildup of azathioprine metabolites into the bone marrow, and that will further damages the bone marrow. So that can not be inactivated or excreted from the body if the person is having poor metabolizer category. Another example, warfarin, which is inactivated by CYP2C9 family, right? So CYP2C9, agar if the patient is having poor metabolizer category, again, then they cannot inactivate warfarin. What happened next? Warfarin associated with the bleeding risk. Excessive high warfarin level increases the bleeding risk. Another example, clopidogrel, prevention of stroke के लिए दिया गया है. What happened next? Clopidogrel is activated by the CYP-C19. Poor metabolizer cannot activate clopidogrel. Patient does not receive its stroke prevention properties. Many of the time we can see this cases like that, that the dosage is given, whatever the conveniency we are having, we can prescribe and deliver to the patient, but still a person is having a stroke attacks, not having the effect of clopidogrel. Why? One can be the reason of genetics or genomic makeup. Okay, so, but we can say this is easier said than done. Obviously, the hardest barrier to using a pharmacogenomics information in the clinic is relating gene to outcomes, right? While codeine example seems very straightforward, most of the drugs have such a complex metabolic pathways which involving a multiple enzymes. बहुत सारी ऐसी दवाइयां हैं, many of the drugs are there that required a multiple enzyme to digest. That will make it a complex understanding of pharmacogenomics. This is very difficult to predict what will be the patient response to a particular drug. Further complicating the situation and genetic changes in the drug transporters and receptors. So this is the challenge in the genomics, as well as non-genetic reasons such as age, gender, another concurrent diseases condition, and drug-drug interaction, diet, other environmental factors are there. Those are the factor affecting drug absorption, metabolism, right, excretion, everything. Those can we can be having a pharmacological principles. Now let's understand what types of gene drug interaction we are having. Now I think the concept is clear. What is the importance of pharmacogenomics in our field? I think that is clear. I every time say it, this that to everyone, that you need to understand your why, right? Why this topic, why this course, and what is the importance of it? How can we practically implicate that learning into our daily life, right? So, if you are a pharmacist and if you are having a store or a clinical pharmacy practice setting or whatever you are doing in your field, if you are aware about this genomic makeup, and if you are dealing with a special population like a lactation mother, or if you are dealing with a geriatric population, pediatric population, if you have any doubt in a painkiller which is prescribed or any kind of medicine which is prescribed, you can raise a query, right? That the genomic testing should be done before prescribing this. If it is convenient to patient, they might have that or not, that is up to them, but you as a pharmacist should be aware about it, that what its importance. That's the only reason I was started that lecture with a very serious example of it, so that you can have a better understanding why we are studying this course, right? Let's understand what can be the types of gene drug interaction. Types can be vary, we can say, based on multiple things. We are having types based on we can say metabolism interaction, transporter based interaction, target based interaction, and immune related interaction we are having. Now let's understand one by one by their name only. See, metabolism based interaction might be having something related to the enzymatic activity, right? Transporter based interaction, some proteins are needed to transport it, right? So those are having interaction with the transporter, and some of them are having a direct interaction with the target, which can be enzyme, which can be receptor, and some of them are having a immune related interaction too, based on their immune system, that might end up with the allergic reactions, right? So let's understand. Metabolism based interaction includes enzyme variation. For example, with the interaction of CYP450 family, we have a very good example. Just understand codeine and CYP2D6, right? Next, we are having a transporter based. So, genes which are encoding a drug transporters that impact a drug absorption and elimination, we can say. Okay, so they are be having a transporter interaction with the gene. That is an example of SLCO1B1 with the statin interaction. Very popular example. SLCO1, that is 1B1, this is the gene which is required to synthesize a particular protein, which is a solute carrier organic anion transporter protein, which are a family of the particular enzyme, which are responsible for transport a particular uh, thing to convert it into the another form, which is the active form, and your drug is going to interact with the transporter. So this will be the type of the gene drug interaction. You can see here the atorvastatin example. The very popular example is the simvastatin actually, but I have found this particular statin diagram which is very convenient to understand, so I have put it. But you will be having an article, n number of article actually, on simvastatin with the SLCO 1v1 gene interaction, right? You can see here in the intestinal cell, atorvastatin is getting converted into the active and inactive metabolites by the CYP3A4 and 5 enzyme. But if there is a transporter that will be transporting something, for example, यहाँ पे atorvastatin, transporting towards the other form of it, then it will be inhibiting the whole process. So if you have a SLCO1B1 mutation, what happens next? Your statin drug cannot be excreted from the body as it should be. Okay, जो जितना expect कर रहे हो उतना नहीं होता है. So there is a buildup of statin drug into the blood metabolites. So basically that is how the transporter based interaction occurs. Next interaction we are having, that is the target. Target based meaning genetic differences in the drug targets, that can be of receptors, that can be of enzymes. Target can be vary, right? In this, we have the example of VKORC1 gene with the interaction of warfarin. Now, this is again a very popular gene, vitamin K, epoxide reductase. Okay, this is the enzyme. Vitamin K, epoxide reductase is an enzyme, and to synthesize this enzyme, we need a gene, and that is the VKORC1, right? So, basically, this gene is providing instruction to make a vitamin K epoxide reductase enzyme, which are responsible for what? Instruction to give the clotting time. Okay, so which is very important for the blood clot. It helps to turn on clotting protein in the pathway that clots the blood. And you know the warfarin mechanism, I hope. So warfarin may induce if there is any alteration happens in the VCORC1. What happened next is epoxide reductase enzyme won't be synthesized, and if it is not synthesized, your warfarin mechanism metabolism get altered. Okay, high warfarin may induce the risk of bleeding, internal bleeding, right? So that can be the example. And another thing we are having, that is the immune based interaction. Certain genetic makeup, we can say, predict a several drug reaction. For example, human genetic markers are responsible for it. And example, HLA-B, for example, human leukocyte antigen B, and particular variant in this category is 57.1, and those are having interaction with the abacavir. Now this abacavir is very popular drug in the HIV, right? And those are having, you will find article also according to it, that if the person is having HLB positive, then they are not supposed to give the abacavir if they are having a HIV test. Okay, so doctors are always suggesting the HLA-B test if before prescribing the abacavir tablet. So that is the immune related interaction. Patient might get the allergic hypersensitivity reaction if person is having HLA-B positive and having a treatment of abacavir. This is nothing but a gene drug interaction examples. Okay, let's understand what is genetic inheritance. To understand it, I think there is a class 12th, we can say, a fundamental thing and concept. But let's understand it, what is the genetic inheritance, because inheritance is a term which is very popular, right? That is a heredity, basically. Inheritance is the way that the genetic information is passed from parent to a child. Member of the same biological family tend to have a similar characteristics, including physical appearance and the likelihood of developing a genetic conditions. See, this is the genetic inheritance, very popular diagram. If the unaffected father and the carrier mother is, having a baby, then that might be the four possibility: unaffected child, male; unaffected female child; carrier female child; or a carrier, we can say, a male child, right? So these are the heredity, we can say. The each of the chromosome will have a allele and they will trans inherited into the child, and because of that the number of the things proceed further, right? Number of events are there, sequence of events are there. Let's understand what are the types of inheritance. See, it is important to understand the basic law of inheritance to appreciate how the conditions are passed on to the family. An accurate family history is a valuable tool. First of all, when the patient is coming with the Alzheimer like situation, or the when patient is having a normal condition like diabetes, the first thing to do is the taking family history. It's a very valuable tool to illustrate how the conditions are passed down through the generation. A person has two copies of almost every gene, one copy from mom and one copy from the dad. Scientists have studied that the human genes to learn how they normally work and how the changes in the gene can further change in their work too. Some changes are minor and do not affect at all. And these changes are, we can say, often called a single nucleotide polymorphism, SNPS, right? Very popular term. Other changes, we can say, are mutations. Those are those that require the medicine to treat mutations, right? And for some conditions, family members with the same mutations may not have the same symptoms at all. So for other conditions, individuals with the different mutations can have similar characteristics too. This is inheritance, okay? This is because of gene expression is influenced by the genes as well as by the environment too. Diseases which are caused by the mutation in the single gene are usually inherited in a simple pattern depending upon the location of the gene and whether the one or two normal copies of the gene are needed or not, right? So several basic models of inheritance are there, exist, and for the single gene disorders, we are having a autosomal dominant, we are having autosomal recessive, we are having X linked, we are having X limited, we are having co-dominant. But before further taking towards the types of inheritance, we need to understand the very basic concept, which is dominant word का मतलब क्या है, recessive word का मतलब क्या है, what is the meaning of recessive, what is the meaning of dominant, what is the meaning of autosomal. right? What is meaning of X linked? What is the meaning of X limited, codominant, right? So this is very important. However, it is not necessary. Not all the genetic condition will have the follow the same pattern. Okay, will not it is not possible at all, and there is always a gap. So in another forms of inheritance, we can say there are another terminology, that is a mitochondrial inheritance, which is not listed here, but we'll discuss in later lecture, mitochondrial inheritance, right? Let's understand what is the meaning of autosomal, what is the meaning of recessive, and what is the meaning of dominant. Okay. So, what is dominant? See, dominant mutations are expressed when only a one single copy of that mutation is present. Okay, only a one single copy is required to have that phenotype of particular thing. You can see the picture here. You can see a purple and a pink color. But if a one single copy is inherited, then the the fetus or the child has the same number of the thing. Okay, same condition. Dominantly inherited genetic diseases tend to occur in every generation of the family. However, we can say dominant mutation can also happen in an individual for the first time with no family history at all of the condition, and those are the category of, we can say, spontaneous mutation. Okay, so those are the type of dominant. What is recessive in this thing? Recessive further requires a two mutated copy. The single type is not enough. In recessive type of inheritance, or we can say genetic inheritance, we require a two mutated copies for the disease to develop. So this is the carrier father and carrier mother. Both are carrier here. So they will be having a recessive things. Okay, 50% of chances that their children may be having a carrier thing. Okay, they will also carry the same genetic mutation. So for recessive, we required a two mutated copy. For dominant, we required only a one copy. So this is how the category has fallen. See, this is a very interesting, and autosomal meaning a specific gene is not on a X chromosome. See, X-linked chromosome, X limited and codominant is a very vast subject to understand, but you can have a brief on it, that autosomal meaning it is not present on a X-linked chromosome, and if you are having a X-link, then it will be having a X-linked chromosome activity. Okay, we'll understand this one by one in the later lecture, because each of these have a role in the genomics. Okay, so we'll understand it. See, this is the heritance pattern and characteristics of it, and the diseases examples. So you will have a clear idea. If you are having a autosomal dominant, what do you mean by autosomal? Autosomal meaning a gene which is not located on a X-linked chromosome, and dominant meaning a one copy is required. So each affected person usually has an affect parent, occurs in every generation, right? Dominant meaning very clear, occurs in every generation. We have a very first disease example, that is the Huntington's disease. Now this is very popular, HD से भी वो जाना जाता है, that is the Huntington's disease, and inherited condition it is, in which a nerve cells in the brain breaks down over the time. Okay, they are having a number of symptoms into the Huntington's disease, which can include a muscular symptoms. So they are having a lower limb activities get decreased, upper limb activities are getting decreased, behavioral changes, they are having cognitive symptoms, they are having psychological symptoms, mood imbalances, confusion, hallucination. Those are the symptoms of Huntington's disease. That might be completely depend on which type of patient is having, what kind of category into further the disease. Next, we are having the neurofibrillomatosis. Neurofibrillomatosis, also known as NF, the condition that causes tumor to form in the brain or a spinal cord or a nerves. Uh, for that condition is very popular, neurofibrillomatosis, right? Next, we are having, that is the echotrophoplasia, and that is basically a dwarfism. Okay, dwarfism is the most common type. We can say it is characterized by the short-limbed dwarfism. The patient is having a short limb characteristics in this. Familial hypercholesteremia, that is a wide popular phenomenon that is very easy to understand. Cholesterol level is getting increased, right? That is the autosomal dominant. Autosomal recessive. Autosomal again meaning that is not linked with the X chromosome, and recessive here means two mutated gene is required. So you can see the characteristic. Both parent of an affected person are carriers and not typically seen in every generation. Very easy to understand. We are having an example of the diseases, that is the Tay-X disease. Tay-X, the pronunciation is Tay-X disease. Also known, this TH disease is a, having a different terminologies. Gangliosidosis is also a popular name of the particular disease, which is a rare inherited disorder that destroys the nerve cells in the brain and the spinal cord. Sickle cell anemia, that is very common and understandable. Cystic fibrosis is again understandable, and another terminologies we are having, that is phenylketonuria. Phenylketonuria, a rare inherited disorder again, uh, which causes an amino acid, buildup. That is the phenyl, I think phenylalanine, which get builds up in the body. Phenylketonuria is a condition. X-linked dominant, females are more frequently affected because all the daughters and no sons of an affected man will be effective from this condition, can have affected males and females in the same generation if the mother is affected. Because X-linked dominant meaning here is if the person is having one mutated gene, only one, then the dominant word will be there, right? And if it is a X-linked dominant, then the females are more high at risk. We are having hypothalamic rickets. It is a disorder of a bone mineralization caused due to defects in the renal, handling of phosphorus. So if your kidney is not functioning well and phosphorus is getting built up, then the hypothalamic rickets that is generates. Next we are having, that is the ornithine transcarbamylase deficiency. That is the most common यूरिया cycle disorder. Very popular I think, और उसके articles भी बहुत popular होते हैं, that urea cycle disorders in the human. Okay, that is a very common condition. Next we are having X-linked recessive meaning two mutated genes are required. Males are more frequently affected males often present in the each generation. Okay, hemophilia A, we are having hemophilia, also hemophilia A, which is also known as a classic hemophilia, right? It is a genetic, again a bleeding disorder caused by the low level of factor 8. Factor 8, very essential for clotting. Next, we are having a Duchenne muscular dystrophy, that is also known as DMD, inherited disorder again of progressive muscular weakness, typically in the boys. Very common in that category. Next and last, we are having a mitochondrial, very rare condition it is, can affect both the males and the females, but only passed on by the females because all the mitochondria of all children come from the mother and can appear in every generation, right? We are having an example of Leber's hereditary optic neuropathy. It is a mitochondrially inherited degeneration of retinal ganglion cell. वो क्या रिजल्ट करेगा? Acute or subacute loss of central vision is the symptom of Leber's hereditary optic neuropathy. We are also having Kevan-Sayre syndrome, that is again known as oculocraniosomatic disorder. Oculocraniosomatic disorder again, which is inherited mitochondrially. Okay, so these are the examples of characteristics and examples of genetic inheritance. Points to take home from this lecture is, what is epigenomics? Okay, the two different terminologies are there, combinedly used, and the principles of it. Next we are having CYP450 enzyme role, because we had a good example of a particular case, and that was the origin of pharmacogenomic study. Okay, so we need to understand about CYP450 enzyme, what its role and its metabolism, what its family. Gene drug interaction, what it is, and the types of gene drug interaction. We are having types of it. Types meaning metabolism type, transporter type, immune based type, and the another one, right? So there were the four types of gene drug interaction. Example of genetic diseases and the DNA profiling. So these DNA profiling, I think we are having in detail lectures of DNA profiling. In next lectures, we have personalized medicine and social ethical issue. In then later words, we are having DNA profiling testing. We will try to understand, to decode what the profiling results are, how to elaborate it, okay, what to understand it, what to understand from the DNA profiling, how we can modify those, how we can adjust those, how we can prevent mortality rates from it. So everything will be covered in this 4 days. But today's lecture was very basic because I must know that you have the concept clarity of pharmacogenomics. what it is and how it works. And by the next lecture, we will jump towards the higher points of genomics, right? Okay, thank you. The session is open for question if you have any. Okay, if you require slides, um, we will try to give it to you. Will you share the slides? Yes, I think at the end of the 4 days, we'll try to share. I have done a poster in my second semester of mine. I love genomics. Oh, very good topic to understand actually. What are equipments needed for pharmacogenomics? See, there are many of the equipments are there. Okay, PCR based, there are sequencing. We will try to understand in next lecture because those are the topics to cover in the next lecture. Equipments, right? Thermo Fisher also has the equipment for it. And many of the technologies are there. Micro errors are there. CRISPR based genomic editing. So those are the things to cover in the next lecture. You need slides? Okay, we'll try to provide it. Okay, very interesting question. What is the difference between pharmacogenetics and pharmacogenetics and pharmacogenomics? Okay, you are trying to say what is the difference between pharmacogenetics and genomics? Very good question. See, genetics is the very old branch, right? Pharmacogenetics that comes with the idea of person's gene is having a link with the drug response. Pharmacogenomics suggests person's response towards the drug is depending on the gene. But genomics is something, more come up with a more detail. For example, if the group of the patient is having fever, a group of the patient is having fever and everyone was provided with the Dolo 650. Okay, but some of from the group might be having good response, some of might be having bad response, some of might not having response at all of Dolo 650. Then जो अच्छे हो गए उसको छोड़ दो, बट जिनका रिस्पॉन्स हमें नहीं मिला, what is the reason behind not responding towards the same dose? That's where genomics stands. Okay, so genomics is dealing with to identifying a patient's own genetic makeup, lifestyle, diet, environmental factor, concurrent disease condition, and then prescribing a something which is convenient to a patient. So that is pharmacogenomics, right? Genetic is a very old branch to study, and genomics is recent here, I mean that is 100-year old. Okay, so that is the main difference between genetics and genomics. I think another question. What does 1,5 in the context of allele indicates? It is a subfamily and superfamily associated, or we can say having a more classification in detail. So they are having numbers of it to indicates the alleles. Okay. Thank you. Genome is different from genetics as acetaminophen depends on Acetylation, yes. How quick are the result of genetic sticks? Are they quick enough to make changes in the drug dosage? See, we are working on it, right? As an Indian population. See, we are having, I would love to answer this question because we are having genetic counselor also. Genetic counseling is there in our field, but in this country where the family is something new to the people, genetic counseling is something, doctors are not aware about it as much. So we need to clear that space of understanding of genetics testing importance, because that is also having some social and ethical issues with it. People are having more stigma of it and not having that understanding of the importance of genetic tests nowadays. As per my understanding, genetic tests are not as compared to like one week ke baad report. No, that is not the way. But it is like after 24 hours, after 48, depending upon the how and what kind of test the person needs. So you can make a drug and the doses change after suggesting the genetic testing. Is it the enzyme which decides the metabolism or the allele? See, this is very basic. It is enzyme which decide the metabolism or the allele. Enzymes are responsible to convert your inactive form into the active form. And to make this enzyme, अगर आप एंजाइम के केमिकल स्ट्रक्चर को जूम करेंगे, यू विल फाइंड दी अलियल्स. ओके, सो दोज द क्रोमोसोम and the makeup of your enzyme, so that's where your allele stands, right? A role of artificial intelligence in gene drug interaction of pharmacogenomics. This is the topic of our fourth lecture. I will be glad to see this question because AI का बहुत बड़ा रोल है इसमें. And I included into the fourth lecture AI in the in gene interaction, how AI can help to identify certain genetic condition which can be previously identified. Okay, you would like to hear about RNA and mRNA, sRNA. Okay, we'll try to discuss gene expression to transcription, translation, protein synthesis. Link of the article. Okay, we'll try to share in the group. Thank you. Please share the slide so we can prepare for the test. Okay. Any other method? Is there other method dose adjustment in the gene mutated population? Any other method is there? Genetic profiling and genetic testing is the ultimate solution for it, because genetic is something which symptomatically cannot diagnose, right? देख के तो पता नहीं चलेगा उसका genetic makeup क्या है. Just the one solution DNA profiling का है and testing का है. We are having regimens that are specified for whites and brown and South African. Already we have generalized regimen. Oh, good. Thank you. You are waiting for AI in pharmacogenomics session and opportunities for family. Okay. We will discuss this in the fourth lecture, but before that, we have lots of things to discuss in genomics and personalized medicine, because next lecture is tomorrow, I think, and that will be a very interesting, session, because we will talk about personalized medicine. So how we can design a particular formula and how we can introduce into the patient's treatment regimen, right? So personalized medicine and social ethical issues समझने के बाद you will move forward with the another things. Okay. If you have any other question, we'll having a whole week to ask. So note it down and we will discuss for sure. You can unmute yourself if you want to ask anything.